A cardiac cycle is the sequence of mechanical and electrical events that occur with every heartbeat. Now, the heart is shaped like a cone, and it contains two upper chambers, called atria, and two lower chambers, called ventricles. Now, the left atrium receives oxygenated blood from the lungs via the pulmonary veins, while the right atrium receives deoxygenated blood from all of our organs and tissues via the superior and inferior vena cava. From the atria, the blood flows into the lower chambers of the heart. The left ventricle, which pumps oxygenated blood to all of our organs and tissues via the aorta, and the right ventricle, which pumps the deoxygenated blood back to the lungs via the pulmonary arteries. Each heartbeat consists of two phases: systole, which is when the heart contracts and pumps blood out of the ventricles, and diastole, which is when the heart relaxes and ventricles fill with blood. Now, the cardiac cycle graph is used to express events during one cardiac cycle. Along the y-axis are aortic pressure, left atrial pressure, and left ventricular pressure, heart sounds, ventricular volume, right atrial pressure curve, and ECG, while along the x-axis is time. But before we continue, here's something to keep in mind. Since there are no valves separating the right atrium from the superior vena cava and the jugular veins, the jugular venous pulse will follow the same pressure changes as the ones that arise in the right atrium. In other words, an increase in the atrial pressure will result in an increased jugular venous pulse, and vice versa. Therefore, below the right atrial pressure curve, let's write JVP for jugular venous pulse. And right above the graph, we'll write the 7 phases of the cardiac cycle. The first phase is the atrial contraction, which lasts about 0.1 seconds. Next, isovolumetric ventricular contraction, rapid ventricular ejection, reduced ventricular ejection, are phases of ventricular systole, and together they last about 0.3 seconds. The last 3 phases, isovolumetric ventricular relaxation, rapid ventricular filling, and finally reduced ventricular filling, also known as diastasis, are phases of ventricular diastole, and together they last about 0.4 seconds. Now, the first phase of the cardiac cycle, atrial contraction, starts with the firing of the sinoatrial or SA node, which sends an electrical signal that propagates outward through the walls of the heart and depolarizes the atria. On the ECG, this corresponds to the P wave. Now, atrial depolarization is followed by the contraction of the right and left atrium. And as the atria contract, the pressure within the left atrium increases. Now, as the atria pumps blood into the ventricle, the ventricular volume increases, and therefore the ventricular pressure slightly increases. At the same time, as the right atrium contracts, an increase in the right atrial pressure will be noted as the A wave on the right atrial pressure curve. In some conditions, such as ventricular hypertrophy, during this phase, the fourth heart sound, S4, can be heard. This sound is caused by vibration of the stiffened ventricular wall as the blood is pushed from the atria into the ventricles. The next phase of the cardiac cycle is the isovolumetric contraction. On the ECG, this phase begins with the appearance of the QRS complex, which represents ventricular depolarization. Ventricular depolarization is followed by ventricular contraction. But prior to ventricular contraction, when the pressure within the ventricle exceeds the atrial pressure, atrioventricular valves close, producing the first heart sound, S1. At this point, both the atrioventricular and aortic and pulmonary valves are closed, so the blood volume within the ventricles remain the same, hence the term isovolumetric. But the ventricles contract, so ventricular pressure increases rapidly. However, in the left ventricle, the pressure doesn't exceed aortic pressure, so the aortic valve is still closed. At the same time, there's a slight increase in the left and right atrial pressure because the increasing ventricular pressure makes the atrioventricular valves bulge into the atria. This increase in the atrial pressure is registered as the C wave on both left and right atrial pressure curves. By the end of the isovolumetric contraction, the pressure within the ventricles becomes higher than the pressure within the aorta and pulmonary arteries, so the aortic and pulmonary valves open. This event marks the start of the next phase, rapid ventricular ejection. This phase is called rapid ventricular ejection due to a sudden ejection of a large amount of blood from the ventricles. Now, as the left ventricle ejects the blood, the pressure from the left ventricle is equally transmitted to the aorta. In other words, both ventricular and aortic pressures reach their maximum. At the same time, the volume of blood within the left ventricle decreases sharply. On the ECG, this phase matches the ST segment, the flat section of the ECG between the end of the QRS complex and the beginning of the T wave, which represents the period between ventricular depolarization and ventricular repolarization. Now, as the ventricles eject blood, the ventricular pressure decreases and the atrioventricular valves return to their neutral positions. This makes the pressure within the left and right atrium decrease, which is noted as the X descent on the left and right atrial pressure curves. At this point, atria start to accumulate blood from the lungs and systemic circulation that will be ejected during the next systole. Moving on to the fourth phase of the cardiac cycle, reduced ventricular ejection. On the ECG, this phase is marked by the beginning of the T wave, which stands for ventricular repolarization. During this phase, the blood outflow isn't caused by ventricular contraction. Instead, it occurs due to inertial energy of the blood. Therefore, on the graph, you can see that ventricular pressure starts to decrease. In addition, the volume within the ventricle gradually continues to fall because the blood is still moving out of the ventricle but at a slower rate. At the same time, aortic pressure also starts to fall since there's less blood leaving the ventricle. On the other hand, the pressure within the atria starts to increase because they continue to collect blood that will be used during the next cardiac cycle. At this point, ventricular diastole begins. On the ECG, the start of this phase is marked by the end of the T wave. During this phase, ventricular pressure continues to fall since ventricles are relaxed. Also, since the aortic pressure is now higher than the left ventricular pressure, blood starts to flow backward toward the heart. This backflow of blood results in a small dip in the aortic pressure graph, which is called the dicrotic notch. Once the left ventricular pressure falls sufficiently, the aortic valve closes in order to prevent the backflow of blood, and this is the second heart sound, S2. It's important to note that the aortic valve closes before the pulmonic valve. At this point, atrioventricular valves, aortic valve, and pulmonary valves are closed. In other words, there's no blood entering or leaving the ventricles. Thereby, the volume within the ventricles remains the same. Thus the name isovolumetric ventricular relaxation. The V wave is still going up, since atria are still filling with blood. From this point on, there are no ECG changes until the next cardiac cycle starts. The volume of blood within the ventricles remains the same until the ventricular pressure is lower than the atrial pressure. Once this happens, the sixth phase, or rapid ventricular filling, begins. When the atrial pressure exceeds the ventricular pressure, the two atrioventricular valves open, and the two ventricles start to fill rapidly with blood from the atria. The opening of atrioventricular valves leads to a rapid fall in atrial pressure, which is noted as the Y descent. Once opened, rapid filling of the ventricle produces the third heart sound, which can normally be heard in children. While in adults, the presence of the third heart sound probably indicates that there's volume overload or ventricular dilation. The last and longest phase of the cardiac cycle is reduced ventricular filling, also called diastasis. During this phase and the previous phase, the ventricles get about 90% of the blood, while the other 10% they receive during the first phase of the next cardiac cycle, or atrial contraction. In other words, we can say that 90% of ventricular filling occurs before atrial contraction. Thus, it's called passive ventricular filling. Finally, during this phase, aortic pressure continues to fall. Alright, as a quick recap, the cardiac cycle refers to the sequence of events that repeat during each heartbeat, and the cardiac cycle graph is used to express them. There are 7 phases of the cardiac cycle: atrial contraction, isovolumetric ventricular contraction, rapid ventricular ejection, reduced ventricular ejection, isovolumetric ventricular relaxation, rapid ventricular filling, and reduced ventricular filling, also known as diastasis. Isovolumetric ventricular contraction, rapid ventricular ejection, and reduced ventricular ejection are the phases of ventricular systole, which is the phase of the heartbeat when the heart contracts and pumps the blood out of the ventricles. On the other hand, isovolumetric ventricular relaxation, rapid ventricular filling, and reduced ventricular filling are the phases of ventricular diastole, which is the phase of the heartbeat when the heart relaxes and ventricles fill with blood.
Cardiac work, also known as stroke work, is similar to the concept of work in physics. In physics, work is defined as force times distance. Stroke work can be thought of as work performed by the left ventricle to eject a volume of blood, defined as stroke volume multiplied by mean aortic pressure. And here, stroke volume corresponds to distance, whereas mean aortic pressure corresponds to force. Stroke work is best represented by a pressure volume loop. Pressure volume loops are graphs, where the pressure inside the left ventricle is on the y-axis, and the volume on the left ventricle is on the x-axis. Each loop represents changes in ventricular pressure and volume over the course of one cardiac cycle, or one heartbeat, which includes both ventricular systole, or contraction, and diastole, or relaxation. The lower right-hand corner is the end diastolic point, and it's the point in the cardiac cycle when diastole is over. At this point, the mitral valve between the left atrium and the left ventricle closes, leaving the left ventricle filled with the maximum volume of blood, called the end diastolic volume. And then systole begins, which is when the left ventricle contracts to push that blood into the aorta. Ventricle contraction makes the pressure shoot up, but for a brief period of time, both the mitral and aortic valves are closed, so left ventricle volume doesn't change. This phase is isovolumetric contraction, but it doesn't last long, because eventually the pressure inside the left ventricle exceeds aortic pressure, making the aortic valve pop open, and that starts the ejection phase. During the ejection phase, blood from the left ventricle goes into the aorta, decreasing left ventricle volume. The left ventricle continues to contract, so ventricle pressure rises further, but then falls slightly. Finally, when aortic pressure exceeds left ventricle pressure, the aortic valve closes, marking the end of systole, or the end systolic point. At this point, left ventricle pressure is called end systolic pressure, and left ventricle volume is called end systolic volume. And the difference between end diastolic volume and end systolic volume is the stroke volume. After that, ventricle diastole begins, so the left ventricle muscle relaxes, making pressure fall. However, both the mitral and aortic valves are closed, so the volume remains constant. This phase is isovolumetric relaxation, and the atria fill with blood during this time. Eventually, the pressure in the left atrium exceeds that of the left ventricle, so the left mitral valve opens and blood flows into the left ventricle. As the left ventricle fills with blood, left ventricle volume rises back to its end diastolic volume, and the pressure increases only slightly. This relaxation phase continues until the mitral valve closes, letting the loop start all over again. All this happens during one heartbeat, and stroke work during one heartbeat is proportional to the area inside the loop. In other words, the bigger the loop and the more the area inside of it, the more stroke work our heart does. In a related concept, cardiac minute work is defined as work per time, or how much work the heart muscle does over 1 minute. In terms of cardiac function, cardiac minute work equals mean aortic pressure times cardiac output, where cardiac output is defined as heart rate or beats per minute times the stroke volume. And since mean aortic pressure can be calculated as stroke work divided by stroke volume, we can replace that in the equation and see that cardiac minute work is equal to stroke work times heart rate. Cardiac minute work has two separate components, pressure and volume work. Pressure work is the amount of work the left ventricle must produce in order to push the blood past any downstream resistance, which can be physiological, like aortic pressure, or pathological in conditions like aortic stenosis, when the aortic valve has a narrower opening. So the left ventricle must exert a much greater force to push the blood into the aorta. Volume work is the amount of blood that the left ventricle moves per time and can be thought to be equivalent to cardiac output, which is defined as stroke volume times heart rate. For example, in strenuous exercise, the heart rate increases and therefore increases the cardiac output or volume work. Additionally, cardiac minute work is directly correlated with myocardial oxygen consumption. Interestingly, pressure work takes up much more myocardial oxygen consumption than volume work, which is why overall myocardial oxygen consumption does not correlate well with cardiac output. Looking at the aortic stenosis example again, the increase in pressure work greatly increases myocardial oxygen consumption, but less blood actually makes it past the narrowed aortic valve opening, so volume work decreases. It's also interesting to look at the difference between the two ventricles with regard to the pressure work they normally perform. So even though both ventricles pump the same amount of blood, the left ventricle has to overcome the mean aortic pressure of about 100 millimeters of mercury, while the right ventricle pressure needs to surpass pulmonary artery pressure, which is only 15 millimeters of mercury. So although the volume work of both ventricles is the same, the pressure work of the left ventricle is greatly increased. So normally, the left ventricle wall is thicker than the right ventricle wall because it performs more pressure work and therefore requires more oxygen. In pathological conditions like systemic hypertension, where the systemic vascular resistance is increased, aortic pressure is higher than normal, so the left ventricle must perform even more pressure work. Over time, the left ventricle wall thickens even more in order to compensate, which is called left ventricle hypertrophy. Similarly, in conditions like pulmonary hypertension, pulmonary pressure is higher than normal, and that causes right ventricle hypertrophy. This increases myocardial oxygen consumption and keeps things balanced for a while. Unfortunately, though, if left untreated, ventricular hypertrophy can eventually progress to ventricular failure, which is when the ventricles can't pump enough blood to meet the body's needs. Alright, as a quick recap, stroke work is defined as stroke volume times mean aortic pressure, and cardiac minute work is stroke work times heart rate. Stroke work is best represented by a pressure volume loop, and stroke work during one heartbeat is proportional to the area inside the loop. Cardiac minute work is directly correlated to myocardial oxygen consumption and can be divided into pressure work and volume work. Pressure work uses much more oxygen than volume work. In some conditions that increase ventricle pressure work, like systemic or pulmonary hypertension, the ventricles adapt by thickening their walls.
If you've already watched the first video on pressure volume loops, then you'll know that the pressure inside the left ventricle is on the y-axis, and then the volume of the left ventricle is on the x-axis. And each loop represents one cardiac cycle. So that's ventricular systole and diastole. It's basically just a heartbeat. The bottom right-hand corner of the graph is called the end diastolic point. And you guessed it, that's the point in the cardiac cycle when diastole is over. So at this point, the mitral valve is closed and the left ventricle is filled with the maximum amount of blood that can be inside it. And that amount is known as the end diastolic volume. After that, the left ventricle contracts, and that's the beginning of systole. When the ventricle contracts, it makes the pressure shoot up. But because the mitral and aortic valves are still closed, the left ventricular volume doesn't actually change. So this phase is called isovolumetric contraction because iso means the same and volumetric refers to the volume. Eventually, after the pressure's been getting higher and higher, it ends up being higher than the pressure inside the aorta, so that forces the aortic valve to pop open. And that's the start of the ejection phase. In the ejection phase, the blood is squirted out of the left ventricle into the aorta. And so as this happens, the volume in the left ventricle goes down. So the left ventricle continues to contract and ventricular pressure keeps on getting higher and higher, but then it starts to fall a bit when the aortic pressure exceeds the pressure in the left ventricle. At this point, the aortic valve shuts, and this is the end of systole, which is really imaginatively named end systolic point. So to continue our theme of really imaginative names, the pressure in the left ventricle at this point is called the end systolic pressure, and the volume in the left ventricle at this point is called the end systolic volume. Now I know what you're thinking, that's all too exciting, but if you think that's exciting, then get this. So the difference between the end diastolic volume and the end systolic volume is called the stroke volume. After all of this, the left ventricular muscle starts to relax, and so the left ventricular pressure starts to fall. But the aortic and mitral valves are still shut, so the volume remains the same. So you remember how when the ventricle was contracting, but the volume remained the same, we called that isovolumetric contraction? Well, now it's isovolumetric relaxation. After a while, the ventricular pressure drops so low that it's lower than the atrial pressure, so that causes the mitral valve to open, and then blood rushes from the left atrium into the left ventricle. As the ventricle fills up with blood, the volume rises back to what it was at the end diastolic point, but the pressure only increases a little bit. This relaxation phase goes on until the mitral valve shuts, and then the loop can start all over again. All of this stuff happens during just one heartbeat, and with every heartbeat, or stroke, the heart is doing work, and that is called stroke work, and it's proportional to the area inside the loop. So in other words, the bigger the loop and the more area inside of it, the more stroke work is being done. Sometimes this is shown to look like a box, which is basically just drawn over the top of the pressure volume loop, and it looks like this. The vertical dimension of the box is the distance from the x-axis to the end systolic pressure, and the horizontal dimension is the stroke volume. So in terms of stroke work, it would be the area inside the box. And the box isn't exactly the same as the loop, but it's a good approximation. Okay, so now we know what a normal pressure volume loop looks like, but let's go ahead and change some stuff up and see what it looks like now. First of all, let's increase the preload by adding more blood to the left ventricle during diastole. So that means that during diastole, this bottom line goes further, and that increases the end diastolic volume. And then, because of the Frank-Starling relationship, there's a nice big strong contraction. And the isovolumetric contraction phase doesn't look any different, but once the blood gets ejected, it becomes pretty clear that there's going to be a larger than normal stroke volume. And then the end systolic pressure and volume end up being about the same as what they were before. So overall, an increased preload leads to a larger pressure volume loop, and that means increased stroke work. Okay, now let's try out another change. Let's say we increase the afterload by increasing the blood pressure in the entire arterial system, including the aorta itself. That means that during isovolumetric contraction, the pressure in the left ventricle has to get higher than it was before because it needs to exceed the aortic pressure, which is higher. That's the only way we're going to get the aortic valve to open. During the ejection phase, relatively high pressured blood leaves the ventricle until the aortic pressure is higher than the ventricle pressure. And since there's elevated blood pressure in the aorta, the end systolic pressure ends up being higher as well, and that means that there's a relatively small stroke volume. It also means that there's more blood left in the ventricle at the end of systole. In this situation, there's a bit of a trade-off, because there's a smaller stroke volume, but there's higher pressure. So it means that the stroke work works out about the same, remaining relatively stable. So we've tried out two changes. Let's go for one last change and up that contractility by giving a medication that makes the heart contract more forcefully. Increased contractility means that during the ejection phase, the blood is under higher pressure, and so the ejection phase goes on for much longer. The ejection phase comes to an end when the left ventricular pressure is the same as the aortic pressure. So they have the same end systolic pressure, but now that point occurs with a much smaller left ventricular volume. So in this situation of increased contractility, there's now a big increase in stroke volume, so there's a larger stroke work. And even though the end systolic pressure is unchanged, because the blood is under higher pressure, it means that the size of the pressure volume loop is bigger. Okay, so that was quite a lot of information to take in, but let's just quickly go over the main points. So, pressure volume loops can be used to visualize the effect of a changing preload, afterload, and contractility. An increase in preload and contractility increases the size of the pressure volume loop, and therefore it increases the stroke work. An increased afterload, though, increases the pressure but decreases the stroke volume, and so that means that stroke work remains relatively stable. Pressure volume loops are graphs where the pressure inside the left ventricle is on the y-axis and the volume of the left ventricle is on the x-axis. Each loop represents one cardiac cycle, including both ventricular systole and diastole, or more simply, one heartbeat. Alright, let's start at the lower right-hand corner. This is the end diastolic point, and it's the point in the cardiac cycle when diastole is over. The mitral valve, or the communicating door, between the left atrium and the left ventricle has just closed. And as it closed, it made a long, loud sound, kind of like a... That's known as the first heart sound, or S1. So at this point, the left ventricle is filled with a maximum volume of blood, known as the end diastolic volume, which is normally about 120 millilitres. You can imagine the ventricle as a relaxed sac of muscle that's full of blood, so the pressure is low. After that, the left ventricle contracts, and that marks the beginning of systole. This makes the pressure shoot up, but since both mitral and aortic valves are closed, blood can neither enter nor leave the ventricle, so the volume doesn't change. This phase is called isovolumetric contraction, and it lasts for about 0.05 seconds. Eventually, the pressure inside the left ventricle reaches approximately 75 millimeters of mercury, becoming just higher than the pressure inside the aorta, forcing the aortic valve to pop open. This pressure reflects the pressure in the aorta right at the beginning of the ejection phase, or the lowest that the blood pressure in the aorta is going to be, and it's known as the diastolic blood pressure, or DBP for short. Okay, now, once the ejection phase starts, it lasts for about 0.25 seconds. That's when blood is ejected out of the left ventricle and into the aorta, decreasing left ventricular volume. The left ventricle continues to contract, so ventricular pressure keeps rising further. Meanwhile, blood is rushing through the aorta, so its pressure increases as well. In fact, during this phase, left ventricular and aortic pressures are essentially equal. This goes on until they reach a peak of about 120 millimeters of mercury, known as systolic blood pressure, or SBP, before finally starting to come down again. The difference between systolic and diastolic blood pressures, in this case 120 minus 75, equals 45 millimeters of mercury, and this is called pulse pressure, because it reflects the throbbing pulsation felt in an artery during systole. Eventually, aortic pressure exceeds the pressure within the left ventricle, so the aortic valve snaps shut. As it does this, it makes a short, sharp sound, kind of like a... And this is called the second heart sound, or S2. So, this marks the end of the systolic period, also known as end systolic point. At this point, the volume inside the left ventricle, known as the end systolic volume, is normally about 50 millilitres. If we calculate the difference between the end diastolic volume and the end systolic volume, we'll get the stroke volume, which is the volume of blood the left ventricle ejects or simply squeezes away on every heartbeat or stroke during this ejection period. In this case, 120 minus 50 is a stroke volume of 70 millilitres. Stroke volume is a useful measurement, but it can vary based on the size of the person's heart. So another helpful measurement is the ejection fraction, which is the stroke volume divided by the end diastolic volume. In this example, it's 70 divided by 120, which is about 58%. In other words, 58% of the blood volume in the left ventricle gets pumped out during each heartbeat. Once the aortic valve has closed, the ventricular muscle starts relaxing, so pressure within the ventricle falls. However, all valves are closed, so the volume remains consistent. This is the isovolumetric relaxation phase, and it lasts for about 0.15 seconds. Eventually, the pressure drops below the left atrial pressure, and that allows the mitral valve to open. Due to the pressure gradient, blood from the atrium flows into the ventricle, at the beginning passively and at the end with an extra push due to the atrial contraction. As the left ventricle fills with blood, its volume comes back up to 120 millilitres, or its end diastolic volume, while its pressure increases only slightly. Actually, this relaxation phase goes on for kind of a long time period compared to the previous phases, about 0.55 seconds, until there's no more pressure gradient between the two heart chambers, and the mitral valve closes, letting the cycle start all over again. All this happens during one heartbeat. And with every heartbeat, or stroke, the heart is doing work, and that's called stroke work, and it's proportional to the area inside the loop. In other words, the bigger the loop, and the more area inside of it, the more stroke work our heart does. Alright, as a quick recap, pressure volume loops are graphs showing the changing relationship between the left ventricular pressure and the left ventricular volume during a cardiac cycle. Pressure volume loops can provide us with useful information such as stroke volume or end diastolic volume, as well as systolic, diastolic and pulse pressure.